Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Mike Berkowitz, Electronic Editor for JAMA and the JAMA Network.
Great. So our first paper today is the characteristics of healthcare organizations associated with clinician trust, results from the Healthy Workplace Study. And we've got first author, Dr. Mark Linzer, joining us. Welcome, Mark.
Hello, Seth. Hello, Michael.
Hey. Well, thanks for joining us. Why don't you tell us what did you do in the study?
Well, there's been considerable recent interest in clinician trust in the organization and why this might be important, but very little empiric data about that. So we conducted HWP from 2011 through 2015. There was a cluster randomized study of work life, clinician wellness, and patient outcomes in 34 practices in the upper Midwest and on the East Coast. And among several other organizational culture variables was a variable on trust in the organization. So for this paper, we assessed the relationships between trust, other work-life factors, and clinician outcomes, such as stress, burnout, and intention to leave the practice.
Okay, and it looks like you had 165 clinicians, mostly physicians, from internal medicine and family practice clinics, and looked at things like basically how is trust correlated with other domains, so work control, cohesion, emphasis on quality versus productivity and communications, and alignment of values with leadership. And what did you find?
That's exactly right. We first looked at our variable of trust. What is trust? And found that trust included a sense of belonging, organizational loyalty, responsibility to help clinicians in need, and attention to patient safety. So those are the aspects of trust. And when we put those together into one variable, we found exactly what you said, that trust related to organizations or individuals who felt they could control their work or their workload or workplace, cohesiveness among the clinicians, an emphasis on quality instead of on a large focus on productivity, an emphasis on communication between clinicians and their colleagues, and then values alignment between clinicians and leadership. All those were strongly associated with trust.
And then, not surprisingly, as you show in Table 3, there's a correlation here with clinician satisfaction and trust with the organization. Can you talk about that?
That was the strongest finding and considerably stronger than any others. Satisfaction, which is a proxy measure for joy in work, a major focus of work today by the IHI and other organizations, was substantially higher in people with trust. And even more so as trust improved over time. So let's say trust eroded and was restored. Satisfaction was the variable that improved the most over time and the most strongly correlated with improved trust through time.
Great, interesting. Mike, what do you got?
I just wanted to ask Mark a couple clarifications. So this was originally a cluster randomized trial.
That's true.
I understand this is an analysis of the data from that trial. What was the intervention? What were you looking at in the original study?
Yes, so the original Healthy Workplace publications separated the groups by intervention versus control. This particular project did not, but the interventions were work-life interventions that would improve stress, satisfaction, and burnout within the doctors based upon baseline data collection. And so we did things like workflow redesign, so redesigning the way in which docs do their work in primary care, improved communication between provider groups, organizing meetings with meaning where people felt that there was a very important link to meaning and purpose in their lives, and then quality improvement programs focused on chronic disease that would offload some of the work from the docs, so they shared the care with their team members. And all of those were quite successful.
Great. So in this analysis, are you pooling people who were exposed to the intervention as well as the non-intervention arms of that trial?
That is true. In a future study, we plan to separate out the intervention and the control arms and look at trust not only in the providers, but also trust in patients and how that all relates to the outcomes for the patients.
Good. And so a lot of these measures, I assume, are instruments, which is a fancy term for kind of survey scales where you assess physicians' attitudes, opinions, emotions about these variables. Is that right?
That's true.
I wanted to know whether you have a sense when I read this, I wonder whether these variables are related to one another. So you have an exposure variable, which is trust, and an outcome variable, which is satisfaction or organizational characteristics, but they seem to be aliased in a way that you might. I'm wondering whether you're measuring the same things in the exposure and the outcome, or whether these in fact are kind of independent constructs, or kind of the background work you've done to demonstrate the relationships between all these different variables, which seem to be getting at the same kind of attitudes and experiences of physicians.
It's a great point. And, these are overlapping constructs in some ways. None of them are exactly the same, and almost none of them, to my knowledge, are collinear. If anything correlates greater than 0.8 on a scale from 0 to 1, it's considered collinear, and it's probably the same variable. So our variables tend to be overlapping, but I don't think that they're collinear, and they're probably not the same constructs.
Okay, good.
Interesting. And I mean, just what you were talking about with the satisfaction, the workflow, communications really resonates with me. I have a colleague who's one of my our residency's assistant program directors who put it really well. He was talking with residents, what can we do for wellness this year? Do you want to have a pizza party, or can we get you a keg? What sort of thing? They're like, no, we don't want to have to make 4 phone calls to get a lab result. They're like, oh, ha, ha, ha. No, what can we do about wellness? Like, we don't want to make 4 phone calls to get a routine lab result.
A pizza's a lot less expensive than that intervention.
Right, exactly. And that it's...
That's a good point.
Yeah. Yeah.
That's a good point. In fact, that's the point, isn't it? I mean, it's that there are things we can do for ourselves, and there's nothing wrong with those things. I just had pizza. It was great.
Right.
But it wouldn't be my answer to how to fix my work life.
Right.
And so what we like about this type of work that we're into, and it's why we've done it for the last 20 years and why we're still doing it, is that it gives you actionable data that you can actually change an organization. So nothing is more satisfying for me than meeting with a CEO or a chair of a department or a leader of an organization and making change. So these are some of the sort of the key actionable findings the implications. First is that trust can be measured and tracked over time. So if people want to know if people trust their organization, we can tell them. Yes, they do. No, they don't. And what aspects are successful of trust and which ones are not. The next is that there are cultural factors within the organization that can be addressed to improve it. And you've mentioned them, Seth. So cohesion, communication, quality versus productivity, and values alignment. Those are culture factors, and each one of them has a way we can go after those. The third is that if you can improve trust over time, people say, well, what am I going to do about it, and what's going to happen if I do it? Well, if you improve trust over time, you can actually affect satisfaction, stress, and decrease by a factor of 2 the odds that somebody will want to leave the organization. So your retention is going to substantially go up. And the last is that there were some gender differences in trust, men being more trusting of their organization than women, that need to be explored in future work. This has been seen before and raises some important questions about where this comes from and how to address that.
Right. Well, that sounds like a whole big barrel of monkeys that we could.
Right. I want to ask a follow-up, which is purely speculative, but we've been publishing a lot on increasing female representation in medical leadership. I'm wondering whether there are synergies, whether you think that those results would change, or whether you have the evidence whether a female leadership of a medical center or of a practice leads to more trust among female clinicians, and likewise with men, whether men are trusting their organizations more than women because there's a kind of a male leadership. I wonder if you could comment on that at all.
Good question. Don't have the data on that and haven't seen the data on that. I'm looking at table 2, which shows the 2 ways in which men and women differed in terms of their trust. And one was just a high degree of trust in the organization was much higher in men than women. But the other is there was a great deal of organizational loyalty among men, more so than women. And I don't know if that's going to be affected primarily by the gender of the leader. It may be affected by the policies that are implemented that make people feel that they're supported, not burning out. When we look at our data by gender, we have published several papers on gender differences. Women feel much more pressure during the workday, more time pressure in their visits, more burnout, more stress, a faster pace of work, and less control of the work environment. All that needs to be studied for where does that come from and what can we do about it.
Yeah. And I'm curious, Mike, to your question is, especially with how underrepresented women are in leadership in medicine, and
Right.
most other places, if there is a difference, like you described or hypothesized, if it's the type of organizations that have women leaders that are able to engender more trust, and not the women leaders themselves.
Good point.
I don't know.
And I think we're close to closing out, but I want to point out that JAMA, since February, has been publishing a series called Trust in Healthcare, which addresses a lot of these issues. There are viewpoints there about teachers, trust between teachers and learners, between governments and organizations, between organizations and their clinicians, and so on, that pick up on a lot of these themes. Mark, I suspect you're aware of this ongoing series of viewpoints, which began appropriately enough on Lincoln's birthday, our best president, and the honest Abe, who we all trust. So check those out on JAMAnetwork.com, because there's a real tie-in to some of the themes that come out of this research.
Great, and thanks for joining us.
And thanks for
Thanks, Seth. Thank you, Michael.
JAMA Network Open. Appreciate it.
Thank you.
Take care, Mark.
Bye.
Okay.
All right.
What's next?
Well, switching gears a
Yes.
fair amount. Next up is the association of mineralocorticoid receptor antagonist use with all-cause mortality and hospital readmission in older adults with acute decompensated heart failure by Drs. Yaku and colleagues from Japan.
From Japan, right. So this is an observational study, real-life registry-based data about the use of MRAs, mineralocorticoid receptor antagonists, which I think are spironolactone and eplerenone,
Yep.
in real clinical practice in hospitals in Japan.
Right. And just to note, I'm going to say spironolactone because 90-something% of the patients receive spironolactone and not eplerenone, which I don't think I've ever heard of before.
Oh, okay.
And MRA means some other things on Twitter where a lot of our viewers are, so I just want to avoid that. And I clearly can't keep saying mineralocorticoid because that is going to be a
Okay.
mouthful.
So tell me what they did. I mean, I may have just said what they
Sure.
did, but
You
tell
did
me
say
what they did and
Yeah.
what they found.
So basically, they took about 4,000 patients from, 19 hospitals across Japan, 2014 to 2016, patients who were admitted for acute decompensated heart failure, or more colloquially, heart failure exacerbations. This was not an intervention trial, but they looked at patients who were, after discharge, were prescribed either spironolactone or not prescribed spironolactone, and saw how the patients did, looking primarily, their primary outcome was a composite measure of death and hospital readmission, but then obviously looked at the elements of that as well. They then also did some propensity score matching where they looked at, if patients were, should the patients have been as likely to have received spironolactone or not, et cetera, as you've described many times before, very much better than I can. And then lastly, did some matching as well, looking at Huff Puff versus Huff Rough, which is just fun to say, but basically heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction. So basically, ejection fractions above or below 40%.
Right. And because we're talking about language, some of the cardiologists that I know, which isn't everybody, call it HFpEF rather than Huff Puff.
Huff Puff.
But in any event, what was a surprise to me, which was hugely surprising to me, is that only a third of the patients in the study had reduced ejection fraction. When I think of acute decompensated heart failure, I think of reduced ejection fraction. EFs of 15, 10, 10 to 20%,
Right.
and people in what we used to call, or maybe still call, congestive heart failure, like fluid overload.
Right.
But 2/3 of the patients here were heart failure with preserved ejection fraction, which is really only defined as an ejection fraction greater than 40%.
Right.
I don't think of HFpEF patients. I think of them as having heart failure symptoms, dyspnea on exertion primarily, but not as being acutely decompensated in the same way.
Well, I mean, I think the kind of patients that we see with heart failure exacerbations, in my experience, tend to be a mixture of both. I think from all this, I'm not an expert on the pathophys and epidemiology of this stuff, but it certainly seems like most patients have some sort of mixed picture of diastolic and systolic failures. And we certainly see, and I certainly see in my practice, patients without a chronic reduced ejection fraction who come in with the same kind of heart failure syndrome of fluid overload, dyspnea, et cetera, we consider acute decompensated heart failure. For me, one of the biggest things that as I started to, go through residency, learn about heart failure, is that heart failure exacerbation isn't just one thing. There's, I think, probably 6 clinical scenarios, which are very terribly named clinical scenarios 1 through 6. And that it's not all just one thing. But basically that, you don't need to have an EF of 30 to come into the hospital with a heart failure exacerbation. And it's not just, you need Lasix.
Right. Okay.
Yeah.
So good to know. So
Right.
most of these patients were preserved ejection fraction.
Right.
And what they found, are you going to say or am I going to say?
You can say.
What they found was that an association between the use of these agents, primarily spironolactone, as Seth suggested, and a reduction in heart failure hospitalization, but their primary outcome was a composite of all-cause death and heart failure hospitalization. So they found the reduction in the composite, but it was mostly due to heart failure hospitalization, and there was no statistically significant difference in all-cause mortality.
Right. Yeah. And if we show figure 2 is the all-cause mortality at 1 year, and you can see those lines are about as close as you can possibly get.
Right.
And there's really no difference there, not surprising. And then figure 2C, which shows the 1 year basically heart failure admission rate after the index hospitalization. You can see there is a pretty big difference in the patients who were getting spironolactone at discharge from their index hospitalization tended to do better and not end up back in the hospital. Obviously, like we said, they did the propensity score matching, and some of this could just be that there's some difference in the patients. But in this kind of observational trial, I think they did about as good of a job you can is trying to see if there was a difference in the treatment here without actually intervening.
Right.
There were some other differences. The patients who were given spironolactone were also more likely to be given beta blockers and either ACE inhibitors or ARBs.
Right.
So it's possible that this is just kind of a surrogate marker for are they getting the whole comprehensive suite of outpatient treatments that patients are.
I was going to point that out, right? Because if you look at table 1, which I don't know whether we have to show up, but the entire cohort before propensity matching, as you point out, they're getting more guideline-directed or evidence-based treatments overall, which suggests to me that the matching may be kind of go through the wash with this propensity adjustment and matching, but there may be unmeasurable variables that are making them different, which is kind of essentially what you're saying.
Right. And then what was interesting is there seemed to be more of a difference in the HuffPuff patients than the HuffRuff patients, which is interesting. Again, that this is now we're getting to like third order slicing and dicing of observational data.
Right.
So this is very much hypothesis generating and not an answer.
Exploratory, like Christopher Columbus.
Yes, exactly. We get a comment from Min. Apparently you need to shave because we are starting to look more and more like each other.
Hey, Min, thanks for joining. We missed you. You've been gone for a few episodes.
Yeah, too many flights, I think. And this kind of stuff's just interesting to me because, I don't do this kind of discharge medications on admitted patients because I admit people to the hospital or don't admit them in the first place. I do a little bit of management of patients' medication as in this subgroup of patients for discharging. But these were pretty sick patients. The mortality, it was 93% of the patients who were initially admitted in the index admission survived the discharge, so 7% or so are dying. Is a pretty sick group. These were by definition part of how they described their population in the first place was patients who got IV treatments for heart failure. So, a relatively sick population of heart failure patients who were coming in the first place. But yeah, if nothing else, it's these are patients who certainly should explore more about spironolactone from their background. What they're describing is we know from the 90s, spironolactone in the management of chronic heart failure without exacerbation is probably or has a mortality benefit. But for patients who actually get the heart failure exacerbations, it seems like making sure they're on optimal medical therapy, and is there a difference in treatment? There's some good questions here.
Yeah, I was a little surprised. They end up concluding these findings suggest that MRA treatment at discharge may have minimal, if any, clinical advantage, which seemed overly strong. So when you're talking about heart failure hospitalization, that's a subgroup analysis in an observational study. So that is, as you suggested, extra exploratory, but I thought this was a little too dismissive of the findings, particularly in the context of the TopCat trial, which in 2014 showed that these agents in a randomized investigation had the same effect in terms of reducing heart failure hospitalization. That's a huge thing for these patients if you can reduce hospitalization. So I didn't think that this was as negative as the authors portrayed it.
Right, I totally agree. That struck me as well. I'm reading this whole thing, and the setup was like, oh, this is helpful, and then big switch there.
Right.
And I totally agree. Death is an objective marker that we mostly all agree on most of the time.
Correct.
And with things like getting admitted to the hospital in the first place, getting treatments, getting readmitted are there are subjective elements to whether or not that happens, but that's still, not being in the hospital is to me a worthy goal. And there's a difference. There was an absolute risk reduction of about 6%. It was 19% versus 25% in the 1 year admission. I would take a pill every day if it kept me out of the hospital for
absolutely, a year. Or to keep your parents out of the hospital with heart failure. Absolutely.
Yeah, absolutely. So, again, this is retrospective, observational, or maybe not, whatever. But it was this was an observational trial. We can't say that spironolactone kept people out of the hospital, but the patients who got spironolactone did seem to do better than the patients who didn't.
Right. So this isn't evidence enough for me, and I would posit for anybody to not prescribe these agents if there were no contraindication.
Right. And just one methodology point here is I think this is a good example of composite outcomes. And I think they use the composite outcomes very responsibly here, where there are basically two outcomes, and you could either die or be in the hospital, and together there was a difference. But if you separate it into the two different clinical scenarios, dying or being in the hospital, there was a difference in one and not the other. These were also, I think, pretty responsibly comparable outcomes. I've heard jokes, you could have death, rehospitalization, or hangnail as your composite outcome, and if all the differences in hangnail, is it really a positive trial?
Right.
So this is just a good example that I might go to in the future, because the graphs, if you look at all three of the outcome graphs, it's composite. There's composite, death, readmission. It's perfect. It's exactly what it should be.
So I'm just gonna put a ring on that and say that I agree. The composite outcome, both of the outcomes were one's important, which is they're both important, but mortality is quote unquote objective. Heart failure hospitalization is possibly a process measure, possibly a quality of life measure, but they both point in the direction of the same dynamic for patients. I think they're patient-oriented or patient-centered outcomes, and they didn't stuff the composite outcome with lots of things. So those are, in general, some principles that you want to follow if you're going to kind of gather a lot of individual items together to boost your power to detect an effect for an intervention in a trial or an observational study.
Yep, absolutely. All right, so moving on to the table of contents, a couple other papers from last week's release. I know you love this one, rate of memory change before and after cancer diagnosis.
Right, so we talked about this before we were on screen. Tell the viewers what this purported to show.
Okay, so basically they looked at patients over a number of years and basically measured their memory on a couple instruments and found that patients who got diagnosed with cancer had higher memory function overall throughout the study. They had a little bit of a drop in their memory function right at their diagnosis, but overall their trajectories of memory loss as they aged was still slightly slower in both parts of the curve before and after their cancer diagnosis than their peers who didn't have a cancer diagnosis. I would have said, if not for a lot of the background information, both in the paper and the invited commentary, I would have been a little more dismissive here because there's a lot of things like competing risk, et cetera, all sort of collinearities. But there's apparently, this is one more piece in a larger body of work, that there's apparently some sort of a bit of a, conundrum where patients who get cancer and then survive cancer tend to have better memory function overall than patients who never get cancer. And there's more dementia there.
Right. I think I'm going to say it a different way just to make it clear, which is cancer seems to in some way be associated with a reduced risk for dementia. And people who have dementia, and this I get out of the invited commentary that accompanies this, have for some reason a reduced risk for cancer, which ecologically makes sense because if you survive long enough to get not early onset dementia, you haven't gotten cancer in advance.
Right. Or if you have dementia, you forget to smoke.
Right. Yeah. But I don't really know what it means, and I took some satisfaction in the invited commentary that praised this study for its incredible kind of data integrity because they had lots of longitudinal measures, and that's the contribution here.
Right.
But even the commentators kind of had no idea what it meant.
Yeah, there's still not a lot to know what to do with this, but there was also, again, with the background in this, and this study didn't get into all the pathways, but there are things like neurofibrotangles and PIN1 and PSER and all sorts of other ApoE stuff. I don't know, all sorts of alphabet soup stuff that I might have known things about at some point in the past.
We're going to send you back to neurology residency.
Please don't do that. But basically, that there are some pathophysiology pathways that have been helped to describe some of this, and this isn't just some spurious finding. It turns out that some people died and some don't, and there are some difference in these two populations. There actually seems to be, it seems plausible based on the amount of data that there is actually a difference here, and that the people who get cancer and survive might have different brain functioning or different propensity to develop Alzheimer's than their peers.
What do you have next?
That's interesting. It's moving on. Yeah. Next up, changing gears a lot. Again, we're required by law to talk about opioids. So the association of naloxone co-prescription laws with naloxone prescribing. So basically, these authors took advantage of the fact that two states, Virginia and Vermont, unlike the rest of the states, made mandatory co-prescription laws a couple of years ago. So basically, everybody who gets an opioid prescription in Virginia or Vermont needs to have been prescribed naloxone once. And they looked at when those laws went into effect, and not surprisingly, there's a huge spike in when naloxone was dispensed at the pharmacies. It dropped off pretty quickly. Part of that might be because there's not in the news. It's not, people aren't talking about it as much, et cetera. Part of it might be they got their prescription, so now they don't need to have it again for another year or two until whatever the requirement is. But that in those states, there was much higher rates of naloxone prescribing. The numbers were pretty impressive. It's I forget which is which, but basically 80 per 100,000 and 111 per 100,000 in Virginia and Vermont versus 16 per 100,000 naloxone prescriptions in the 10 states with the highest rates of opioid overdose, and then 10 in the remaining 40 states.
So this is just showing that the law was effective in getting the drugs. It wasn't 100%, so maybe it wasn't effective.
But it's still pretty high.
But it was better. It was getting the drugs out, and we don't know whether people use them, whether they put it in their sock drawer and forgot about it, and this isn't a clinical outcome.
Right. Okay. And again, as we've talked about before, every state now has some sort of law making it easier for people to get naloxone without a prescription or with a standing order or something like that. And also, it's always hard to know with these sort of policy interventions is there a difference because the law went into effect, or is the law a marker that the culture is changing in that state and it just bubbled up to the state legislature at that point, and the law, it's not reverse causality per se, but it actually is feasible that there are effective state laws like this because there's been such a groundswell of whatever.
Yeah, but given the difference you described, I think it's the law affecting the change.
Yeah. Go to GEMAnetworkOpen.com, check the graphs on these. It's literally
Okay,
it's pretty impressive stuff. Next up, you actually will like this paper. The Association of Midlife Cardiovascular Risk Profiles with Cerebral Perfusion at Older Ages. So they took patients who they saw basically every 5 years for 5 visits between 1991 and 2013, did their Framingham risk scores every time, and then in 2014 at the end did MRIs to check out cerebral blood flow. And found that basically patients who in their midlife had lower Framingham risk cardiovascular scores had better blood flow at a later age in their brain. And cerebral blood flow is apparently a surrogate marker for dementia, essentially. So patients with healthier hearts in midlife had healthier appearing brains in late life.
Which you can imagine, if coronary risk factors and the other variables that fit into Framingham risk are pro-atherogenic, then your coronary atherosclerosis and your cerebroatherosclerosis are the same process.
Right.
So you're kind of protecting against the same thing with lower absolute CV risk.
Right. And just the old joke that neurology patients have hearts so they can pump oxygen to the brain.
Yes. Okay.
Right. Next up, this is interesting. I'm not sure what to make of this paper, but the estimation of total usual dietary intakes of pregnant women in the U.S. They use the National Health and Nutrition Examination Survey, NHANES, to estimate nutrients or micronutrient intakes in pregnant women in the U.S. And found that a lot of women were still not getting a whole bunch of vitamins and minerals that they're supposed to get. It was A, C, D, E, K, B6, folate, choline, iron.
Wow.
Or no, not iron. Potassium, calcium, magnesium, and zinc. And we all know zinc's very important.
But this is a self-reported food frequency stuff?
It's NHANES, so they were calculating micronutrients from survey data of self-reported diet stuff.
Right.
So, we have lots of questions about how accurate that stuff is. What was also really interesting was that they found that a lot of women were at very high risk of getting too much sodium, too much folic acid, and too much iron. And basically, the folic acid and iron we might be too successful in getting people prenatal vitamins.
Right.
And the micronutrients from those prenatal vitamins and other sources.
But can I'm
Go
sorry.
ahead.
Can you say that and say that you have deficiencies in these other things?
No, especially since
Because
it
those
was
prenatal vitamins have A, C, D.
right. Absolutely, and there's also not enough folate and too much folic acid, and I have no idea what that means.
Okay.
All right. So, but the point is there's at least some signal that we have opportunities to improve prenatal nutrition in the U.S. is what I'd say. And to steal from Michael Pollan, we should eat food, mostly plants, not too much.
Not too much.
Not too much. Next up, analysis of pharmaceutical industry payments in the UK healthcare system in 2015. So as much as the US has all sorts of limitations getting patient level data, we now, since the ACA, have the open payment system, which is how we figure out which industry payments are going to docs, even though there's some shenanigans to hide some of that stuff. In the UK, they don't have a system like that. Most other peer nations don't have a system to track industry payments. There's this kind of voluntary system, what's it called, the Disclosure UK database that I believe is set up by the ABPB or something like that, a big pharmaceutical group that covers about 85% of the pharmaceutical companies in the UK. And they basically found that there were about 100 companies that give an average of about $20,000 in payments to about 4,000 healthcare organizations in the UK for a total of about $72 million in 2015. I'm speaking in dollars because we're in America. They convert it all to dollars, which is nice for us because I don't know what a pound is. And not surprisingly, it's concentrated as you'd expect. About 10 firms are responsible for about 60% of payments. They actually did some Gini coefficients of inequality to show how concentrated the payments were. And most docs and most organizations, most hospitals were getting relatively small amounts of money, and a small fraction of them were getting big amounts of money.
Are these going to institutions or to individual providers?
This was institutions.
I see.
But it's still interesting stuff.
Okay.
Again, it's I think without open payments or an open payments type system, this is kind of the best available data that they have right now.
Right.
So it's.
Do you think institutions are getting grants, restricted or not, from these manufacturers and these companies in order to accomplish clinical aims?
Some of it
you just can't tell.
Some of it certainly could be, but it's hard to tell. And I mean, I know we all know that pharmaceutical companies have the best interest of patients and clinical outcomes.
Right. If anyone's watching from the UK now, when we're live or afterwards, when we're archived, leave a comment and let us know how you're experiencing this, if at all.
Yep. Absolutely. All right. And last up, this is one of those great things where it's both simple, easy, basic, and wonderful all at the same time. They did a pilot RCT in pediatric primary care and showed that of youths who use marijuana recently, they did a computer-based substance screening, and basically then they got the screening in a whatever module before the doc had to see them. And
so what's a youth? Is it an adolescent, like age 11 to 18?
Something like that.
Okay.
I don't remember, and it says youths here.
And
people old enough to smoke marijuana and go to a pediatrician.
And they do a computer-based substance use. Does that mean that tell me what it means?
Yeah, it's like when you're in the waiting room, you get an iPad and you do
Okay.
a little quiz thing about how much marijuana do you smoke, what kind of habits do you have around it. And what's really impressive here is they had real outcomes here where they basically got reported marijuana use in the following 3 months, which went down in the group randomized to the intervention. In addition, they had lower rates of being in a car with an impaired driver in the same 90-day period.
Okay, so what are the two comparison arms? What's the randomized intervention?
People who did and did not get the computerized screening.
So it's not So it's screening and behavioral counseling.
Oh yeah.
Right.
Sure.
So it's presumably this interface tells you not to use so much weed,
right?
Or
and not to be a passenger in a car with somebody who's actively smoking weed.
Got it.
And it seemed to work, which is good.
Yeah.
It also seemed like the kind of thing I think. I'm not a pediatrician, but there's all sorts of barriers in talking to kids about using drugs, about stuff like that. So, maybe if it's easier for the physician to not have to talk to the person face to face, if the person's going to be, I would imagine I'd be more honest talking to an iPad than a doctor about my habits.
Particularly in this age when they're connected to their devices. And I think there's lots of other demonstrations, maybe too few still, but lots of other demonstrations that you can get at sensitive topics with patients by giving them a computer and letting them interact in a quiet space or private space, even though the information obviously is being shared with providers.
And also, So it's hard to get this kind of social interventions into a practice. We've got busy schedules. You've got to see 4 or 5 patients an hour, et cetera. Right. Patients are also waiting, so these two problems can solve themselves.
Exactly. So you can do a lot of that history taking.
Yep. And if you can do an effective intervention while someone's in the waiting room where they're going to be there anyway, and that stops them from getting in a car with somebody who's impaired, that sounds fantastic.
Right. I think another large area where this has been done is domestic violence or intimate partner violence, where they don't need to, even if their partner is accompanying them and trying to control their behavior, they can interact with the screen in a way that's private.
Yep. It's that reminds me of some hospitals, including one of the ones I work at, where there are flyers for human trafficking and domestic violence in the women's bathrooms.
In the bathrooms.
That nobody else sees unless you're in the bathroom. It's a private space, and they'll tear away phone numbers or stuff like that.
Right.
So it's good stuff.
Okay.
Great. All right. Well, thanks for joining us. Of course, go to JAMANetworkOpen.com, read these articles and more. Next release is coming out on Friday at 10 a.m. Follow us on all the usual social channels, Twitter, Facebook, Pinterest. Listen to our podcast. The author interviews are getting pulled onto the iTunes podcast.
What he said.
Yeah.
We'll see you next week.
Oh, no, not next week. Next week we're off for the holiday.
We're off because there is a holiday. What's the holiday? Right. Tell them what the holiday is.
The holiday is the U.S. Independence Day, commonly called July 4th because it falls on July 4th, which was my grandmother's birthday.
It was.
It was.
And the Declaration was actually signed on the 2nd, but they decided to celebrate it on the 4th because they wanted to get the word out to the colonists in Philadelphia and elsewhere.
Very interesting stuff.
And
then the following week, we will be back on Tuesday because you're out of town on Monday.
That's correct.
Yep. So Tuesday, let's presume 2 o'clock Central Time.
2 weeks from tomorrow, we'll see you again.
Yep. Thanks for joining us.
Thanks for joining us. Always a pleasure. Bye.